Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner.
Hi, everybody. Welcome. We've got a great guest joining us today, Professor Christian Blank from Netherlands Cancer Institute. Christian, thank you for joining us today.
Hello, good afternoon. Or good morning for the US.
So Christian, I don't think really needs any introduction, but Christian, it might be fun actually, and I'm sure people will be interested to hear a little bit about your career so far, because you moved around a little bit and done a few different things. And I guess why did you end up, or how did you end up where you are today?
So when I started my studies in medicine, I loved accident and emergency, to be honest. And in the UK, you have this combination of surgery and internal medicine, which I loved a lot. But when doing my PhD, I fell in love with the immune system, and I still am totally in love with the immune system. I think it's aside our heart, the most important organ in our body. And so when I finished my studies, I was thinking, where do I want to go? I want to go for a specialty which knows a lot about the immune system. So it was rheumatology, transplantation surgery, or oncology. And at the end, I ended up in oncology. But I swear to myself, I want to finish in my career that I don't prescribe any chemotherapy anymore. And in melanoma, I have achieved this. So I'm prescribing only targeted therapy and immunotherapies. Yeah, and I started first my career in Germany. Then I've done my postdoc in Tom Gajewski's lab in the US, where we worked on, at that time, a molecule nobody was interested in, PD-1, which became later a little bit famous. And when I was back then I moved after Germany to the Netherlands, to the Netherlands Cancer Institute, and then worked first on PD-L1, PD-1 in stage 4 disease. And then 10 years ago, the Neoadjuvant idea came together with John Schumacher. And this is the hype now coming from.
So how do you find it, Christian? Obviously, you're German, but you work in the Netherlands. Culturally and linguistically, that's one question. And then my other question is going to be, where are your loyalties when it comes to soccer?
I expected this question. And to be honest, I'm very pro-MISC. So I'm for Germany, for the Netherlands, for Italy, and for Austria. And let me explain. So I have very good friends from Austria. So therefore, I'm from Austria. I have very good friends in Italy and learning Italian also. So my heart lies in Italy. And then Dutch and German. These are my two hearts. So living 17 years in Amsterdam, you feel pretty much Dutch already. Even my Dutch colleague will not agree with me.
Yeah, so it's been a bit disappointing so far, hasn't it, at the Euros, I suppose?
Yeah, I have only one bet anymore, yeah. But I believe that, sorry, James, that the Netherlands will come to the finals, yeah.
Yeah, but then Spain will beat whichever team wins the semi-final tonight, is my prediction. But anyway.
Yeah, that's good because, then we can say at least that we became second. We lost to the European champion twice, the Germans and the Dutch people. Yeah.
Anyway, right. So to business, I guess. Sapna's going to kick us off, I think.
Yeah. Sure. Well, Christian, you said it so sweetly at ASCO. You were going to introduce us to a woman named NADINA. So can you just take us through maybe study design and then your top line results from the study?
Yeah. So NADINA was the final and the phase 3 trial from an upfront 8 years of work where we identified which combination, in my view, might be the most efficient and still safe combination to be applied neoadjuvantly. We've previously shown that neoadjuvant application of checkpoint inhibition is superior to adjuvant therapies because it expands the anti-tumor response stronger than when you give it after the removal of the tumor. And NADINA was then the accumulation from all these phase 1 and phase 2 trials that we have done before. So we compared two courses of ipi-nivo with the low-dose ipi upfront the surgery, followed by adjuvant therapy in patients that did not, only in these patients that did not achieve a major pathologic response. So if you had less than 10% vital tumor after your neoadjuvant therapy, you were done after the 6 weeks of therapy. And if you didn't achieve this, then you got 1 year adjuvant therapy, either anti-PD-1 or BRAF/MEK if you were BRAF mutated. And this was compared to the standard of care of one of standard of care therapeutic lymph node dissection followed by 1 year adjuvant anti-PD-1. This trial has two endpoints, one primary that is event-free survival, and a key secondary endpoint where there also the statistics have been made on, that is overall survival. And in the first interim analysis now with a follow-up of 9.9 months, the study met already its primary endpoint, so meaning that there is a p-value of 0.0001, and then showing with a hazard ratio of 0.32 that the neoadjuvant arm is better than the adjuvant arm, and with an estimated 1 year EFS of 83 versus 57% for the patients, which is pretty nice here. Sapna, you are mute.
This was me trying to be good and not have background noise in there. This is an amazing result, Christian. What I think is really incredible about that EFS is the majority of those patients had a major pathologic response. So they were basically finished after surgery, a nice tight course for resectable melanoma instead of this really long, arduous course that can last a year or more. And that EFS benefit, even though there were some non-major pathologic responders in that curve, it still nicely separates. So that's a mixture of people who do exceedingly well with the therapy and people who do fine with the therapy. Even lumping them together, you see this incredible hazard ratio. I don't know if we've had a melanoma trial where that hazard ratio has been so significant. So congratulations on this. It's
at least not if you have a active comparator, yeah, indeed, yeah. So, and it's 60% of the patients that are done after 6 weeks of therapy. That's beautiful for them. And as you said, even the worst patients, so the non-responders, they have at least the same event-free survival of 57% like the control of that. So all patients do even or much better than the control. There is no subgroup that did not benefit from it here at the end.
This is sometimes a point I try to make to clinicians, is that when you use neoadjuvant therapy, even if your patient did not achieve a complete pathologic response, you have done some benefit to their immune system by leaving that tumor there and allowed in vivo T-cell repertoire expansion compared to if you had removed it. You didn't get the best response they could get. You still got better than you would have gotten if you had given them the adjuvant approach.
Exactly. And what the big advantage of neoadjuvant is, and that holds true also for your trial, is that we know something for the individual patients. In the adjuvant setting, you can only speak about the whole population, so you have the chance of that relapse-free survival, blah, blah. But with the knowledge of the pathologic response, you can tell your individual patient what his prognosis is. So if you have a major pathologic response, these patients will hardly relapse. So these patients you can leave really to the normal life. You don't have to follow them so strict. They can buy a house, set up a family, do all the normal life stuff. And vice versa, the non-responders, they still have a benefit if they do neoadjuvant, because they know they are high-risk patients. And so we as the doctors can follow them much more strictly. And when the relapse come, then we can treat a low tumor burden disease with adjuvant therapy and with stage 4 disease therapy, for example. And then they still have better chances because we know that we have to follow them more strict. Yeah. So in that way, all the patients have a benefit if they receive neoadjuvant therapy.
Yeah, it can be really personalized. James, over to you if you have questions.
Yeah, I mean, amazing data, Christian. So congratulations to you and everybody on that. So just to pick up the safety maybe a little bit, Ipi-Nivo, at least at the sort of conventional dose, if you want to call it that, that there's some patients with metastatic disease you might not want to treat because of toxicity. But how do you think the safety really fits in this group of patients? Is it going to be suitable for, the majority of patients who are coming into the clinic? Have you got any concerns about any patients about the safety?
So we have treated patients from 18 to 78. I thought even 80 in the 80s patients. So it's feasible for every patient. And it's funny to see in hematology we first want to cure and then we start to find the toxicity. In oncology, we always think first of toxicity and then about curation. I'm coming from hematology, so I want to cure first 95% of the patients, and I have already ideas how we personalize that we reduce also the toxicity. Yeah? We had 30% grade 3-4 toxicities as compared to 15% in the adjuvant arm. That's definitively higher, and it's also higher than the anti-PD-1 only neoadjuvant therapy. But if you look at the quality of life of the patients, then the curves are identically. And they drop only in the beginning when they have the surgery. And it's funny to see that it's then 6 weeks earlier for the adjuvant arm than for the neoadjuvant arm because they have the operation later. But then they recover exactly to the same and have the same quality of life. So it's more how we have to manage the toxicities for the patients. We have some chronic diseases. These are the endocrinopathies that we have to inform the patient. And I believe in the future when we can really predict by gene signatures which are the favorable and which are the unfavorable patients, then we can improve this even further, that we say that we de-escalate some patients to anti-PD-1 monotherapy neoadjuvant. Some patients can go with the doublet, and some patients might need even a triplet or an alternative doublet. That is 20% patients that we have now that have at 1 year already a relapse. When we can identify them, these patients need even harsher therapies.
Yeah, no, absolutely. So maybe just to ask a little bit about personalization, if you want to call it that, or biomarkers, or what do you think in the next, let's say, 2-3 years are really the most promising avenues for trying to get, I suppose, more efficacy at the end of the day, and also to where you can at least reduce the side effects?
So I believe we can decide or divide the patient into 3 groups. You have a patient group, about 50% of the patients that are at baseline interferon signature high. You can also use T cell signatures or IL-2 signatures. The most robust is the interferon signature. These patients most likely can go with anti-PD-1 alone, and we're waiting for the analysis from Sapna in the SWOG to see in a large cohort what we have described already before in a very small cohort. Then you have a group of patients that we call the interferon signature low-high patients. These are patients that are at baseline low, but become at week 3 already high. So they respond to the combination of anti-CTLA-4 plus PD-1. And in a very small cohort, to be honest, we've seen that these patients have 90% major pathologic response. So these are similar to the highs, patients that have an immune system that can be activated with the tools that we have at the moment. And then we have a group of patients that are low for the interferon signature at baseline, and they stay low. And these are about 25% of the population. And these patients do not respond. They do not respond to PD-1, and they do not respond to CTLA-4 plus PD-1, at least in the low dosing. What we've seen is that patients that receive the high dose anti-CTLA-4, there we see an increase of the major pathologic response in the interferon signature low population. So, for example, with intensifying the combination, I believe that some patients can get an induction in these low groups. Then we've shown that the addition of IL-2 can do something. I believe that a triple therapy of anti-CTLA-4, PD-1, and LAG-3 might be something to go. And then something really experimental things, what we have now suggested to the field, for example, targeting large 1 or making an unspecific stimulation with Staphylococcus enterotoxin B or poly-IC, where you really make an unspecific danger signal into the tumor and then to the draining lymph node, and then you can induce something. So these are ideas I have that we can also give the lows a chance for response here.
I wonder if I might ask a little bit more about this biomarker selection, Christian. As we look at our SWOG data to try to help validate what you found in this interferon signature, should we be testing the primary tumor or should we be testing the lymph node? Or do we know about concordance of this interferon signature between the primary and the lymph node?
So we're working on that. At the moment, the interferon signature is established for the lymph node. What we see from the primary is that the signal is way weaker. Yeah.
Mm-hmm.
So you have to use the RNA sequencing or the nanostring analysis in a more deeper way to get a signal at all, and it's not so robust like in the lymph node. Yeah. So for now, it's the lymph node. Yeah.
That's helpful. And then as you describe this high, or, a person who's high maybe at baseline doesn't even need an on-treatment biopsy. They're high.
No, they remain high. This we have also looked into it. They are high and they come a little bit higher, but they are highs. Yeah.
They're high. And then the low patients, it sounds like it benefits them, obviously start out with doublet and then get an on-treatment biopsy and see if you've converted them from low-high or they remain low. At what time frame would you do that biopsy? After the first cycle, after the second?
After the first. So we have data for 3 weeks. And in NADINA, we have biopsied also a subgroup of patients at 2 weeks, because you can imagine we have to analyze this first. But if you see this already at 2 weeks, that would be very nice, because then your week 3 second course, you can already decide with the patient whether you can go on with the doublet or whether you have to escalate. Yeah. So this is currently in the work, and we are. I hope that within the next months we will have this. But then we can do this at week 2, and then you can design your trials already. That you say week 3, then we give a higher dose of anti-CTLA-4, or we give a triplet. And whether we then need to give only one shot and then operate, or whether we should give then 2 courses of this I don't know, to be honest. At the moment, from the gut feeling, I would then give 2 courses before I operate, 2-3 weekly courses. Yeah.
And then because you were talking about adding, a strategy for these low that stay low, whether if it's going to be enterotoxin, poly-IC, that really sounds like an intratumoral, intranodal, intralesional type of approach. Is that correct? And what did you think of Daramoon and the, intralesional IL-2 that Axel presented? No.
Okay. We can try everything. So I think there's a rationale for SEB, because we have already some mouse data. There's poly-IC. We have published some mouse data on IL-2. Daramoon is definitively a potential combination partner. Our analysis of the high-dose anti-CTLA-4 clear given a rationale for testing also in these patients the escalation of the IPI or for example another anti-CTLA-4. And for sure, the triplet based on the stage 4 data from Paolo, what he presented at ASCO. So I think all of these we should test, and I believe that it will not a one size fits all. It will be some patients benefiting from this, maybe patients that have a very immune excluded tumor. They need an SEB or poly-IC. Patients that have insufficient CD4 help, they can go away with the cytokines. Yeah? Patients that maybe have already a smoldering immune response but not strong enough, they might benefit from higher doses of CTLA-4. Yeah. So I believe in this group we will again having sub signatures where we then can say which patient needs what.
I like that. Maybe over to you, James, about kind of patient selection or treating patients in the real world now, and then we can maybe wrap here. Sorry about that intrusion.
That's all right. You're trying to distract us, weren't you? I would imagine. Yeah. So I mean, Christian, that's amazing. There's just so much interesting stuff to discuss. But I guess the practical thing at the moment, and I'm sure you're sick of being asked about this over the last few weeks. What do you think about the sort of the real world clinic regulatory reimbursement situation? In as much as you can say something briefly, because obviously it's a long story in its own right.
No, okay. It's a long story. So NADINA was not an upfront registration trial, and I think the partners which we worked together thought that we would be already a step further, having new anti-CTLA-4s, and then based on NADINA, try to set up other registration trials. At the moment, I don't see this. So ipilimumab maybe at side with the Agenus compound are the two only really good working CTLA-4 antibodies in the field. Yeah. So in that way, NADINA comes suddenly to be so as important as a registration trial. Yeah. And there are several things that we are working on. What I can say for the US, we have submitted to the NCCN. Omitamid has done this. So for the US, there will be no problem that NADINA meets the grade A criteria of a trial. So then it will get it most likely to the NCCN guidelines. In the Netherlands, we are working on that, and it will be an off-label indication, even compensated without any problems. And for Germany, for example, you can always write a letter to your insurance and ask for individual on basis of the trial. I would love to see that we get an EMA registration, because that would make in Europe things for other countries much easier. I'm working on that, but I can't say more about this at the moment. Yeah.
An EMA registration, Christian, is an investigator can initiate that, or that has to come from a company to get this indication?
It has to come from the company, and it took me 2.5 years to convince the company to make NADINA. Yeah. So give me some time. Yeah. We are now some weeks after ASCO, and I'm pretty sure that we will come to a solution. Yeah.
Good. I mean, I hope they're hearing this. People want to use this. This is real data that shows a benefit, but in the absence of, backing by the company, it makes it hard on an individual physician or provider level to, have to get these one-offs if they could really use this momentum and capitalize. I mean, they have the
that the problem is FDA and EMA are marketing authorizations. They are not medical agencies, what the name is, but they are market access authorizations. So I think that the individual countries and we as the key opinion leaders have to take over also the decision making again. I think what I love about NADINA is also it shows also all the flaws in the system that we have. Meanwhile, yeah,
Sure.
it's like if Mercedes-Benz would just judge their cars themselves, and then are the only one to decide that it is allowed to come to the market. Yeah, you are both laughing, but it's the situation in oncology. If you in the car industry would have this, everybody would say this is not possible. There is a state legislation that decides whether a car is safe and whether it goes to the market and things like that. Yeah, so only in the oncology it's a little bit different, and I think we physicians have given away a lot of what we should do. Yeah, I think that the responsibility for a company is to produce a very good and safe compound. Yeah, but I think we physicians should be the ones who teach the field and learn ourselves also how we use these compounds. And with the construct that NADINA reveals now very nice to the whole oncology field, we learn that we physicians, we key opinion leaders have given away this responsibility at the end. Yeah. So, and this has to change. Yeah. And there are some initiatives at FDA and EMA in that direction. Yeah.
This is the kickoff of the Christian Blank campaign for head
Politics,
of EMA.
yeah.
And you told us a lot. You gave us a little insight there into your car preference. The German and you came out with that Mercedes-Benz reference.
No. I'm driving a Fiat Cinquecento.
Oh, you're
and this is my love. Yeah. So I'm not a big
James
car
is a Skoda
person.
person.
Yeah. No.
James likes Skoda.
You can't say that in public, Sapna. That's outrageous. And also, Christian, you said we were laughing. I was definitely smiling. That wasn't laughing.
Okay. Sure.
Just for the record. Anyway, listen, I think Sapna's going to wrap up, not me. But listen, wonderful data. Many congratulations again. Thanks for making the time. Sapna?
So happy, Christian. It was so wonderful to be there in the audience and see it and just capitalize on all this momentum. So congratulations on everything for the New England Journal of Medicine paper, all the wonderful things. So have a great time there. Thank you so much for making time for us.
Grazie mille, ciao.